Thank you. Good morning. My name is Alfred. I'm from Boston, so I get to work with and learn from Dr. Hulber and Dr. Archer, who you all have heard from today. I'm one of the neurosurgeons, and so I wanted to have an opportunity to talk to you about what people might mean when they say you could have surgery that changes your stroke risk and why that may be the case, even though it's not necessarily particularly common, whether in patients who have sickle cell or other patients. So no relevant conflicts here. The things that I wanted to sort out here during this talk were what reasons you may have for having surgery for moya moya and surgery in the context of sickle cell, and what limits our understanding of that and how it may be different from other patients who have a similar kind of surgery by neurosurgeons frequently. What kinds of surgeries are used to help reduce stroke, whether in sickle cell or other patients. And then finally, what are some of the outcomes and distinguish what people may counsel a patient who has sickle cell from what people may counsel a patient who doesn't have sickle cell but has the same kind of surgery planned. So moya moya, I don't think we've mentioned this term really during this morning yet, but this is something that I would say kind of comes in parallel at a more frequent rate for patients who have sickle cell than patients who do not. That doesn't mean it's common, but that means that instead of 1 in many thousand, it may be 1 in a few thousand or 1 in 1,000. So it's still a low rate, but it's something that's important to pick up on because it's certainly a serious cause of stroke. And as far as I can tell, we don't have data showing that medical therapies are effective at getting rid of the stroke risk that you may have from moya moya, even though the therapies that are currently applied and have been discussed are very effective at reducing the stroke risk you may have from the sickle cell pathology itself. And that's the hydroxyurea, the transfusions, but those may not get rid of the stroke risk from the moya moya. But they are probably somewhat related, and it's important to recognize that moya moya is probably still a broader term than what it really should point to. And as we heard earlier this morning, terminology and language that we use to discuss disease and symptoms is very important, and that can impact what kind of care people get or what kind of care people don't get because of assumptions. So I want you to hear the term moya moya and recognize that that kind of changes the categorization of stroke and the type of stroke that you could experience if you have moya moya plus sickle cell compared to if you only have sickle cell but don't have moya moya. But on the flip side, a lot of moya moya research may not apply as a blank slate onto patients who have sickle cell, and it's important to think about those and make sure that your advocates that think through your sickle cell care are also aware of what recommendations you're hearing and provide a good context to make sure that those assumptions that your surgeon may have about moya moya don't just get thrown onto you because you have maybe a different kind of moya moya. And as we learn more about the genetics behind moya moya disease, there's probably going to be better understanding and more specialized care required for certain patient groups compared to others. Okay. But if I were to describe moya moya, it's a narrowing of the blood vessels that supply the brain. We oftentimes don't know the cause. In a patient with sickle cell disease, it's probably related to some of the abnormal blood cell structure in sickle cell disease and some of the response that it creates on the lining of the blood vessel. But I don't know that we have guaranteed confirmed data on that, but that's a reasonable hypothesis. Okay? And that narrowing then causes an increased risk of stroke, just like if you had narrowing from high cholesterol that then caused a plaque and narrowing of the neck vessels. But this is a vessel right inside the brain, just as it enters the space that's surrounded by the brain. So why would we do revascularization in patients with sickle cell? Well, patients who have sickle cell alone, we know, and this is again contextualized by some of this is old data and it's probably not as severe now, but we know that patients with sickle cell have some rate of stroke that's higher than the rest of the population. But patients who have sickle cell and moya moya, here in the pink line, have an even higher stroke rate. So whatever medical therapy we can use to get rid of or flatten that green line to be more and more normal, that doesn't fully account for that gap between that green line and that pink line. So the surgery may be what's necessary to reduce that gap and bring it down to kind of patients without moya moya. Okay. Some of these pictures are similar to what you've seen before in 2 talks ago, but here, again, we discuss how pictures can really convey it. On this picture on that left-hand side, this vessel right here, this is the time of flight MRI. This vessel that's white, that shows the flow going through that vessel. This is what a normal vessel should look like in a patient either with or without moyamoya, or either with or without sickle cell. But when you have moyamoya, then the vessel can become narrowed. And in this patient, the other side vessel, the left side carotid artery, is narrowed compared to this one. So this person is starting to have that narrowing. And as you can imagine, this left brain vessel that's on the right-hand side of the picture, this vessel and this half of the brain is going to be at a higher risk of stroke. Along those same lines, similar to the pictures you saw earlier where yellow was showing brain stress, we see here that actually this phenomenon, this narrowing, is causing less blood flow to reach here. And so the brain can't even respond to and get that the improved flow to show that there is that stress. The brain tissue here has some amount of normal blood flow, and here it's actually getting less blood flow. So it doesn't even have that stress response. It'd be like if you were so tired, you couldn't get angry or you couldn't get happy, right? If you're at some birthday party, but you were at 5 other birthday parties the day before, and you're just wiped out, and you don't even have the ability to show that response. This is what we're seeing here. And then the oxygen extraction fraction, or how much of the maximum speed limit that your brain can even get to is really maxed out here. So this is still showing that there's that stress response. This is like you're telling people, I can't really kind of stay up for many more hours. And here we do see on the far right picture, some of those little white dots on this kind of picture that show prior stroke. So this is moyamoya. It compromises the blood flow to the brain and can lead to stroke. Sometimes we study children and sometimes we can study adults. Some people may say children are just more adaptable and maybe their brain blood flow can adapt to that problem by using alternative back channels. And this is something that historically back in the 80s and 90s was pretty commonly preached. I specialize in pediatric or children with moyamoya disease, although I also take care of some adults. But I just want to make sure that people also recognize, if you hear from your doctors that, hey, a stroke in a child or moyamoya in a child, maybe they can adapt enough. That's not 100% known, and that's still debated, which I'll show you some of the elements of that debate in the coming slides. But this is what people are talking about if they say collateral. So are there alternative pathways that can get blood past this narrow region? And whether that's fully true in children more than in adults is not known in all cases, but your body is going to try to use some alternative pathways to get blood flow past a narrow point. And at first, it may be enough, but then eventually, as this narrowing progresses, as moyamoya arteriopathy is known to do over several years, then your risk of stroke is gradually going up. And in the overall population who has moyamoya, that risk we might quote as high as 80% of having a stroke over the subsequent 5 years. So it's a serious problem, just like silent cerebral infarcts for patients who have sickle. So it's an on top of the existing problems, and that's why some patients may benefit from surgery. This is a table from one of the papers. They use all these abstract terms, and I always struggle with this, and it takes forever to think through it. So then I just try to translate it for myself so that I can think through it a little bit more quickly. So some of these terms basically are saying how much fuel is going to your brain. And we know that in patients who have, sorry, I'm just looking for the mouse here. I don't see it, okay. So patients, and not even just the patient, but that side of a given patient's brain. This is LVV. I presume that in this case, they're talking about moyamoya as large vessel vasculopathy. Compared to patients who do have it, and then the patients who don't have it, they actually have less kind of ability to give fuel. You can imagine that. The tube that gets that fuel there is smaller, so you have less fuel there. And that means that the car or your brain is using its maximum effort. And ultimately, we see that there's an impact on decreased horsepower of the brain function. The brain tissue itself over time does change. You get less tissue volume of multiple different kinds of tissue when you have this moyamoya arteriopathy. So similar to a lot of the messages about stroke, whether silent stroke or a acute symptomatic stroke that you've been hearing all morning. So moya moya is a problem on top of that. This is a plot that again shows that there is that difference, but it's important to acknowledge not everything that we say is can be taken just at face value. And you see that these two groups here, the clusters, this is patients who don't have moya moya and the patients who do have moya moya on top of sickle. This the data and how I summarize in that plot says this is very different. But you can see there's actually kind of a lot of overlap, right? So even when you have the moya-moya arteriopathy, it still requires a good discussion with you plus all of your medical professionals and the context of your sickle cell disease and how dangerous a surgery might be for you compared to another patient who has sickle cell disease and moya-moya arteriopathy. But there is some overlap here, even though the groups as a whole are different from each other, right? Ongoing uncertainty. Again, kind of translating this to think through it, a lot of experts kind of met in this one paper and talked about if someone has a stroke and if they're found to have this narrowing or the moya-moya arteriopathy, if the narrowing is particularly bad and how severe that narrowing is, and if the narrowing is on the same side as where that stroke occurred, plus is causing actual slow flow and is limiting that brain supply, what would you do? And this is going to be where you see all that uncertainty. So I've circled in green where some people are saying, we all agree and we're very confident. So there's certain scenarios where you have really bad narrowing. It's greater than 70%. It's exactly where the stroke occurred. So you say, well, this follows, right? This ties together. Then people are pretty confident that this patient should have surgery. But there's plenty of other areas where there's no agreement whatsoever. Or 50% of doctors may say, yeah, I would recommend surgery for that patient if I saw them. But that means also if you see a different doctor, you may hear different things. So it's important to acknowledge this field or this subfield still has a lot of uncertainty in it. And I think it's always going to require a lot of discussion between not just you and your surgeon, but you, your surgeon, your primary care doctor, plus your hematologist and the team that's been following you to understand the bigger context there. Are you going to be going towards gene therapy? Are you going to go towards stem cell transplantation? Those are things that change the context of whether or not you would benefit from surgery. And ultimately, some of that is knowledge that we're continuing to work on. These are some more of those different scenarios, which there's a lot of uncertainty about whether or not we should be doing surgery. And so I think if you take nothing else away from this, it's that if you are found to have moya moya on an MRI that looked at the blood vessels, it's something that doesn't mean you have to have surgery. That means you need to have that discussion and think through that and talk through that, again, probably over the course of several visits to kind of get that context with you and your doctors. I want to warn people up in the coming slides, not immediately, there are some surgical images and surgical videos. If people are objecting to that, I'm happy to skip over that. If most people are interested in seeing that, then I'll give you the warning one slide before, and some of the people can either look away or check out their cell phones or step out of the room. I'll give you a moment too. But just in case you do hear about surgery or moya moya in your case or your family or friend, what does that really mean? So there's different types of surgery. The biggest differentiation is whether it's a direct connection or an indirect connection. And those are probably the biggest difference in experience that you may have from one surgeon to another or one case to another. There are other more subtle nuances like which blood vessel you use to give new blood flow or which blood vessel you connect into to receive blood flow. But the direct versus indirect is probably the biggest difference that people are talking to about all the time. So the direct connection, it's like you would think in a plumbing scenario in your bathroom. There's nothing complex about what we're doing from the surgical perspective. We take a tube that has flow in it and we connect it to a tube that isn't having great flow in it. And that's the direct connection. That's a surgical procedure and we suture those vessels together. Okay. This is beneficial because it provides new flow and it's immediate. Once that connection exists, it's working. You can imagine some people who are smaller, kids under 18, the vessels are probably smaller. And so it could be harder to do successfully. Also, patients who have sickle cell can have complications around the time of surgery. The longer you're in surgery, the more likely that you're going to have a complication. And so a shorter surgery is going to be a little bit safer. To do that direct connection, to do those suturing, it takes a little while longer. Just getting the vessels separated out probably takes about 45 minutes, maybe up to an hour. when you're needing to clean it up really well to get that connection to be really clean. And then the connection itself, another 10 to 30 minutes, and then finally closing up. So that's, adding up time for a surgery. And even with that connection, now you're very dependent on that specific connection being clean. Just like if your plumber does an okay job, but it's, the weather changes and it gets a little bit leaky, sometimes it can get clogged up or shut down, and that can be a problem with this technique. An indirect connection, it's almost a misnomer. You actually don't do any connections surgically, but you let the body do its own work. You bring some tissue that has lots of blood flow that won't be affected by moya moya because it's not a brain vessel. It's a skin vessel, or it's muscle tissue, or it's the covering of the bone, the scalp covering. And you put that next to the brain in an area that's at risk. And that close proximity allows the body to do its own growth of new blood vessels. So you're not necessarily dependent on one connection or dependent on the surgeon being able to make a good, clean connection that stays open forever, but the body can grow its own channels. The disadvantage is that it takes time. It takes probably at least several weeks, but that slower effect probably also means that you have more new channels growing in, okay? So for those people who want to step out, the next 2 slides do have some images, some video. If anybody needs a moment, raise your hand as well. I'll pause. I'm not going to move forward until people feel comfortable. Okay, so this is an actual surgical video, just so that you have that sense of what's actually happening. Okay, so this is a magnified, and again, I haven't started the video. Again, raise your hand if you need a moment to step out or. So this is an actual incision. This is very magnified, and so you're really zoomed in. This vessel itself is probably about 1.2 millimeters, so it's still pretty small. And this is a vessel that supplies the skin tissue. And all we're doing here is separating that vessel out so that it can be placed underneath the bone against the surface of the brain. And you see that we're cleaning off that vessel so that you can move it down into a deeper space, right? So here, this is a direct anastomosis I'm about to do. So we cut that vessel completely, fill it with a fluid so that it doesn't clot off while I'm doing additional work. And then finally here, let's see here, we expose the surface of the brain. This means you're taking a window of bone temporarily off. And then now we're looking for the vessels that we can connect it into. You can tell there's dozens of little tiny vessels that are too small to manipulate, but even the bigger ones are about 1.5 millimeters. And this kind of matches with the vessel that we connected from. And then you'll see that we open that vessel up as well, and then do an actual suture connection here. So we're just about to open that vessel. And then here, now it's transparent because it's a super thin wall, right? And we've washed out the blood from that temporarily, and we're actually using little sutures that are 10-0, which, what size is that? It's probably something like 1/100 of an inch in kind of diameter. So it's a very small diameter. And then we're doing an actual connection from the end of that vessel that's from the skin into one of these brain vessels so that we can skip over that area that was narrowed. Now you see that suture line coming together. And then finally, we're going to take away the clips and see that now there's blood flow. You can see the blood pulsating, and now that's an alternative pathway to flow into the brain, right? So that's a direct connection bypass. I've never had anybody applaud, but I'll make sure to ask all of you to come to the operating room every time I do a surgery. But so that's a direct connection. In a similar fashion, we would want to take some of that tissue that can provide blood flow. In an indirect connection, we make a little window in the bone temporarily, and we put that tissue right up against the surface of the brain. So here, this is a short incision. We make a window in the bone here. We make a little gap here so that that tissue has a path in and out, because that's going to need to still be connected to the source of the blood flow. We open up the covering of the brain, and then we suture that material so that it stays there and put the bone over the top again to protect the brain tissue, right? So this is that other kind of approach. This oftentimes takes us 45 minutes from start to finish of the surgery, so you're reducing that risk time. And sometimes that's the right decision as a sickle cell patient, sometimes it's not, but it's going to be something that depends on your surgeon and how bad the blood flow blockage is and exactly what you're trying to target, right? These are some pictures that show the effect of these bypass techniques. This is actually a study of indirect bypass, and I want you to see how effective that indirect bypass can be. You may say, Alfred, that doesn't sound like it's going to work very well, but this is an example of an angiogram. So you hide all the bone tissues when you do an X-ray, you place contrast in the blood vessel and watch how it flows as these little black squiggles. This is an example of pretty much what it looks like normally. These black squiggles are on the scalp, the surface of the head, but then when you have the revascularization, now you see some of it goes through the bone and starts supplying some of the brain. And sometimes it does a reasonable amount here, and sometimes it does really well, supplying almost the entire half of the brain. So this is why some people can benefit from surgery if there's narrowing on top of having the abnormal blood structure or the blood cell structure of sickle cell disease. So what are the reasons and the limitations in comparison with other patients with moyamoya? It's actually interesting. I don't know if I fully believe this data. And again, this is just an example of how you need to contextualize the conversation about the recommendations in your specific case and with your other doctors, not just one doctor saying one thing. You want to hear what a team of doctors are saying because each one is going to have different expertise. And here, actually, it almost suggests that patients who have moyamoya and sickle cell disease have a lower rate of stroke than people who have moyamoya alone. I really struggle to believe that, and I think it's an artifact of who was included in this study and is this a certain subpopulation. So I think it's also important to remember, if there's only one paper about it, it may not be valid to just say this is the absolute truth, right? Maybe they didn't think about certain other aspects that distort their data and their information. This, I kind of believe that patients who have sickle cell disease and moyamoya, if they have a surgery, they're more likely to have a longer hospital stay. I believe that because I've seen it, just because their overall care is a little bit tougher. They may have pain crisis that's precipitated by the anesthetic, by a long hospital stay, changes in the level of circulating fluid. But here we do see data that I think is replicated by multiple different centers. And so we see that, yes, patients who have sickle cell and moyamoya have higher rates of stroke than sickle cell alone. They have higher rates of hemorrhagic or bleeding stroke in addition to inadequate blood flow stroke, because moyamoya also can cause bleeding because the body is trying to open up these alternative pathways, and those vessels aren't designed to be doing that extra work. So they're under higher stress than a normal blood vessel is. So you can have inadequate blood flow stroke or bleeding stroke from sickle cell. Same thing, you can have inadequate blood flow stroke or a bleeding stroke from moyamoya. Right. This is just more of that same data and showing that people are getting hospitalized for these kinds of problems as well. So ultimately, the procedure itself doesn't come without some risks. And certainly we have data that the risk of doing a surgery for moyamoya is a little bit higher if someone has sickle cell disease compared to if they don't have sickle cell disease. And when we cite this for all comers who have moyamoya, we're probably saying about 4% risk of having a serious problem during your hospital stay if you're having that surgery. But it's probably almost double that, up to 8 or even 10% in patients who have moyamoya and sickle cell disease. So that's an important context to remember. Your surgeon may see a lot of patients with moyamoya if you are referred for further evaluation, but how do they counsel you and compare that risk in your case compared to another patient who doesn't have sickle cell? And how do they assemble that team and that anesthesiologist and the hematologist to make sure that they've optimized it and reduced that risk as much as possible for you? Those are areas of ongoing investigation, right? So hopefully, I'm sorry I took 24 minutes, but hopefully it's helped understand some of the reasons that you might do surgery, what moyamoya is, and even kind of a sense of what some of those risks and benefits of doing a surgery may be. And finally, just as other speakers have emphasized, this is only a small subset of the overall team, but I'm highly dependent as a surgeon, even when I see a moyamoya patient, on understanding what Dr. Holbert and Dr. Archer are explaining to me about that individual patient's sickle cell care, as well as the overall trajectory of their course and what some of the particular risks and benefits and nuances in their case. So everything is always needing a team-based approach in order to make sure that you're getting the right care, right? Thank you.